The future in the treatment of multiple myeloma will be, at least according to my opinion, very much determined by novel immunotherapeutic strategies. Most of them currently, at least, are targeting BCMA, which is broadly expressed on myeloma cells, unfortunately not expressed on a lot of other tissues apart from normal plasma cells. And therefore, the toxicity by targeting BCMA using novel immunotherapeutic strategies is rather limited. But what we see with most of these novel immunotherapeutic strategies is some kind of hematotoxicity, some kind of cytokine release syndrome, and also a certain degree of neurotoxicity. We have 3 strategies that are now moving into the clinic, all targeting BCMA, and these are immunodrug conjugates, and the most advanced is belamaf. So it's an antibody drug conjugate in which an antibody targeting BCMA is linked to a cytotoxic agent. And with this, you can see quite efficient therapy in quite advanced patients. So we have seen a high response rate, especially in daratumumab naive patients, or at least not daratumumab refractory patients. It was highly successful. There was some issues about thrombocytopenia, some issues about ocular toxicity, but with split dose and increasing intervals in patients that are experiencing these side effects, it can be quite well managed. So this is one strategy. Another strategy, probably more potent than antibody drug conjugates, are bispecific antibodies linking the tumor cell with a T cell and forming this immunological synapse. The bispecific antibodies are extremely effective in redirecting T cells towards the myeloma cell. The proof of principle study was the AMG 420 study, in which it could be shown that with a very acceptable toxicity at the highest dose level, about 70% overall response rate, 50% MRD negative CRs could be obtained. AMG 420 is a typical biomolecule, so it has to be administered by continuous infusion, which was felt by the sponsor not to be an ideal administration for patients with multiple myeloma. But there are other 7 BCMA-directed bispecific antibodies in the clinic, and we've seen data from 2 compounds now. One is CC-93269, and the other one is called teclistamab, and both are really effective in multiple myeloma, and the administration is much more convenient when compared to AMG 420, so it can be given by weekly infusion, and some of these bispecifics are already developed for subcutaneous application. And with the CC-93269 and teclistamab, we've seen that in spite of this 1 weekly application, still cytokine release syndrome and neurotoxicity are not a real issue. So I guess this treatment will be also applicable to elderly non-transplant eligible patients. So this is something where I think we can really have some hope for improvement in the treatment of patients with multiple myeloma. And the third strategy, which is probably the most effective one, are the CAR T cells, again, mainly targeting BCMA. And we have different constructs now in late clinical development. ID-cell, we have the construct that was developed by the Chinese company Legend, and now also taken up by the Johnson company in the CARTITUDE-1 trial. And in both studies, we have seen very high response rates, up to 100% in very advanced patients with multiple myeloma. And we've seen progression-free survival in some of these studies, especially in patients with complete remission, going beyond 2 years in these very heavily pretreated patients. So extremely effective. And fortunately enough, in patients with multiple myeloma, the toxicity of the CAR T cells seem to be less when compared to patients with lymphoma or ALL. So I think also the CAR T cells will be a very interesting new treatment approach in multiple myeloma. All these strategies have been applied at the very late stage disease, so a lot of patients, fifth, sixth line of therapy. And I guess if we move these novel immunotherapies to the early lines of therapy, they will be even more effective when compared to these applications in late stage disease. So I think from what we've learned at EHA and also at ASCO about these novel immunotherapeutic strategies, they will definitely change the therapeutic armamentarium that we have for our patients. And I'm very optimistic that these new strategies will help us to improve the outcome of our patients considerably.